pretty clear to me that workplace ergonomics was a major contributing factor in my situation. I had no other risk factors that were non-work related.
Welcome to Season 6 of EyeCan, a podcast about ophthalmology through a uniquely Canadian lens. EyeCan is co-hosted by me, Hady Saheb, and Heather O'Donnell. Throughout the season, we'll have guest co-hosts for some of our shows. We will share our experiences as ophthalmologists today and tackle some of the challenges we face as healthcare providers. Season 6 of EyeCan is brought to you by Astellas Pharma Canada and Johnson & Johnson Vision. We thank them for their support. On today's episode of EyeCan, Dr. Rishi Gupta joins me in the co-host seat. Rishi practices diseases of the Retina and Vitreous in Halifax, Nova Scotia at Dalhousie, and is the chair of the COS Ergonomics and Injury Prevention Working Group.
Dr. Hussein Hollands is a clinical assistant professor and faculty member at the Division of Retina and Vitreous at the University of British Columbia. Hussein completed medical school at UBC, ophthalmology residency at Queen's University, and went on to do a medical retina fellowship at University of Toronto. Previously, Hussein had been active in ophthalmology research, having completed a master's degree in epidemiology and has published about 40 papers in the peer-reviewed literature. Currently, Hussein practices in Vernon, BC in the Okanagan Valley, mainly doing medical retina work, cataract surgery, on-call duties, and some general ophthalmology. He enjoys being active and is an avid squash player, as well as enjoying the local outdoors with mountain biking and paddleboarding. He's married to his wife, Anya. They have 2 teenagers and 2 Wheaton Terriers. Dr. Hollands, welcome to EyeCan. Let's jump right into this important topic.
Thank you.
So, Hussein, today's chat is about ergonomics, and I really love how much attention ergonomics is getting in ophthalmology. We hear more about it at our conferences. COS is working on having residency programs be more focused on it. And I think this is just so important for us and the future of the profession, for each of our longevities. And so I'm really grateful that you're here with us to share your learnings and your journey with regards to ergonomics. So can you tell us a little bit more about your medical story and how that story brought you here today to talk to us about ergonomics?
Yeah, absolutely. So very nice to be here. Thank you guys for doing this, and it's great to be chatting with you guys today. And yeah, I totally agree. I think it's excellent that ergonomics is being looked at here throughout, as you discussed. So yeah, a bit about my medical story. I'm a healthy guy, I would say, a healthy weight. I work out and am active in sports and strength training, and I'm a pretty healthy guy. This year, so in the winter, I woke up one day with left-sided shoulder pain. I didn't think much of it. I thought I maybe tweaked it playing squash or something. I was in the operating room a couple days later. The pain worsened throughout the day. I barely got through the OR, and basically I ended up with that day severe shooting pain down my left arm. I had weakness of my arm, numbness and tingling, and it was pretty clear to me that day that I had developed an acute left-sided C6 or 7 radiculopathy in my on the left side. So navigating the medical system for there, I was in severe pain. I had full weakness of my triceps, shoulder, and grip. Navigating the medical system was difficult for me, and that's as a physician who has, I know all the emergency doctors. I'm on call, 1 in 6, and it was difficult. I ended up with a number of trips to the emergency room. I ended up on high-dose oral prednisone. I had an MRI privately, not through the health system. This is all within about a week or week and a half, lying in bed in excruciating pain in my left arm. I ended up having a friend who's a GP. So again, I have a huge connection to the community. call the neurosurgeon after the private MRI. And basically, this was on a weekend. And basically, neurosurgeon called me severe degenerative cervical spine disease, C4 to C7, and with a stenosis causing this left-sided radiculopathy. So this was an acute on chronic situation, and he recommended essentially urgent C4 to C7 spinal fusion, which I got in March of this year. Luckily, I everything has gone excellent. I've recovered very well. I'm fully active again over the last 2 months. I still have tingling and numbness in my left index finger and a little bit of left-sided weakness that seems to still be improving. But I'm very happy with my recovery, but that sort of is the medical story that that brought me in today. So, we can talk a little bit about the contributing factors and so forth. But that was my story.
Wow, what a story. How long did you have to put work on hold as you're navigating, the diagnosis and the treatment? What happened there?
I didn't put much on hold because of our situation. I mean, we all know how busy all of us are, and I have busy clinics. I don't have a quote substitute ophthalmologist to cover me. I might have taken one day off when I was in the really bad pain, and then I took 2 weeks off after surgery. I had about 10 days to plan for the surgery when he offered me the surgery. So at that point, I rescheduled my clinics for 2 weeks, and then I was back at work. But I was working in a lot of pain during that time on, 60 milligrams of oral prednisone and so forth. And really, there was just no other option. It was easy. It was the easiest thing for me to do as opposed to rebooking or sending our patients to wherever they need to go, right? I didn't operate. I stopped operating for sure. But in terms of, and I wasn't seeing elective stuff. I was seeing the stuff I had to do. So I definitely did decrease. I was only seeing stuff I had to do, but the stuff that I had to do, our injections and our urgent patients
was enough to fill your days as you're waiting for surgery.
Yeah.
That's wild. I think that's a topic for a whole other podcast, is just having capacity within our system to allow for somebody like you who needed, time for themselves to take that time. So that's wild.
Something that I hear there, Hussein, is what we hear all the time, which is in the practice of medicine, we sort of do everything that we can for the patient. And too often that can sometimes be at the detriment to the physician, whether that is physically with respect to this topic of ergonomics or, from the wellness perspective and burnout. It would be lovely to continue hearing conversations like this and see if we can evolve to having more physician support, for situations like this.
Absolutely. I 100% agree. Having that support system, having it be something that as a community, we all register and work together, whether that be, within our very local community or within a bigger community to take care of each other, as you say, right? Because that's really, with such a specialized area, that's all we have is our community of other ophthalmologists or physicians, right?
For sure. So Hussein, going back to the injury, what is your understanding of what contributed to this, and how long was this going on prior to this acute episode? What's your understanding of that?
Speaking to my physiotherapist and my neurosurgeon, who I got to know both quite well over the months that we dealt with it, it was pretty clear to me that workplace ergonomics was a major contributing factor in my situation. I had no other risk factors that were non-work related. I didn't have any other underlying medical issues. And describing the the job that I do to the physiotherapist and the neurosurgeon, they were both definitely of the thought that this was a major contributing factor. When we can get into this a little bit more, but certainly, I've been doing ophthalmology like you, Hedy, for 20 years or even maybe a bit longer when you look at the medical school and so forth. And I certainly think overuse of the slit lamp exam in my situation was major. I can't remember the last time at that point, not now, but that I adjusted the chair height to the proper ergonomics for a slit lamp exam. It's just not, I did a little bit, but it's just wasn't a routine part of what I did. It was always easier to have a quick look and move myself to the patient situation. So there's a lot of hunching and stooping over. I do a lot of eye injections. I don't know that was a major contributing factor, but I also in the past have not adjusted the chair height or the proper height. I would always adjust myself to the patient. I'm sure that was some contribution, and certainly the use of the indirect ophthalmoscope for me. I think mainly in the screening setting where you're sort of face to face with the patient. This is more of a discussion for ophthalmologists who do this, right? When thinking through it, I think that when I scleral depress, I think I actually do position the patient well. And I don't think that was a major contributing thing because I do lean the patient back to the right height but I think it's the screening of having a quick look with the indirect that was a contributing factor in terms of the neck position. And also for me, I know would be the laser indirect ophthalmoscopy. So the doing an indirect laser, I certainly end up in bad positions there for sure. That's sort of me looking back. So there's no question that was major contributing factor, at least in my mind and the physiotherapist and neurosurgeon, in terms of just the ergonomics and 20 years of that, and certainly a contributing factor.
That's great, Hussein. Thanks for that review of some of your perspectives on things that have contributed. I'm curious, do you think that when you describe these things, all these things sort of take a little bit of time, a little bit of effort, every patient adjusting, the chair or adjusting your slit lamp, et cetera. Do you think that we have, in general, an issue with education, sort of a lack of education on ergonomics, or is it just a lack of execution because we're seeing a higher volume of patients, and as we go through our day, adding that more time just kind of gets in the way?
Yeah, so I've definitely thought about this a lot for this discussion. So I do think it's multifactorial. I do believe that awareness is really, really important. And I think that if you asked anybody one for one, including a resident or something, and you said, should you adjust the patient height so that you're not stooping over and hunching over your neck, they would say, yes, you should adjust the patient height. If it was a true or false, it's pretty obvious. But the awareness of the importance, I think, is really, really important. And so, yes, I think awareness is important. And then number two would be, you discussed the busyness of the practice, and we all have busy practices, absolutely contributing to this in terms of repetitiveness. So the importance of just doing it every time, getting yourself in the right position and not putting yourself at that risk because of, what you sort of said earlier too, which is that if we're not healthy, we can't help people, right? We can't take care of our patients. We can't be there for our families. We have to be healthy first, so you have to make that a priority to put yourself in the right position. But, as I thought about it a little bit more too, and maybe this was something that would come up with a different question, another big thought I think that I had thinking through this, And one of the changes that I've made a little bit more is around the focused clinical exam. You know, a really, just a little bit of a brief anecdote, you know, when I was in third year medical school, my very first rotation was in general surgery, and my general surgeon, the attending, he was a hepatobiliary surgeon. He did one of the top general surgeons in the Western Canada. He did the liver and pancreatic transplants for all over the West. And I remember we had a clinical rounds, and we had a patient there, and there was residents, senior, junior residents, and medical students. And he asked me what I would do for, you know, this particular patient, how I had examined them. And I rattled off all these things I had memorized, you know, you're going to palpate on the various areas and so forth. And I told him I was trying to sort of show him I knew my anatomy of the you know, the abdomen and so forth. And he wasn't impressed with my answer at all. And he said, well, how is that relevant? And of course, I didn't know really what was going on. I was just a third year medical student. But the idea of having a focused clinical exam is really important. And this is very obvious stuff. But when I do think that when we go through residency, we're taught that what you do in ophthalmology is you look at slit lamps and you look with the indirect, and that's what you do. And that's true, but we also have a lot of technology, and I feel like we can minimize or decrease the amount of exam by thinking through being focused on things, right? So when you think through it, you've got obvious situations. You have a PVD check or a uveitis. Well, uveitis follow-up. You need to do a good quality slit lamp exam, or a PVD. You need to do a good quality dilated exam with scleral depression to double check for a tear. But what about a CME check? You've got an optos and you've got an OCT. Do you need to examine that patient? Well, I would argue potentially you don't. You know, you've got a glaucoma follow-up where the eye exam has been performed previously, and you're checking pressure fields and RNFL OCT. Do you need to be straining your neck doing a exam? Like, obviously, we're all going to be thorough. I'm not here to tell anybody what their exam needs to be in any situation. But what I do think we all should do is think about what exams we need to do before we do them. And I think that could minimize our exposure to these examinations. And if it was thoughtful by us as a community, that we would keep up exactly the same thoroughness and, you know, excellence that we all, of course, want to keep up as ophthalmologists and physicians. So I do think that is something in ophthalmology that, you know, if we could, in a focused way, decrease our examination, I do believe that we could keep up excellence and even have some extra time talking to the patients.
Those are all great points, Hussein. I think leveraging technology to save our backs and necks has to be thought about. And one thing that we always have a discussion around in the ergonomics groups is how we can interface with industry to help them understand the challenges that we're experiencing. So I think those are great points.
EyeCan wants to know what you think. Please send your comments on today's episode or any suggestions you may have for topics or features to communications@cos-sco.ca, and we'll try to incorporate them into future episodes.
EyeCan veut savoir ce que vous en pensez. Veuillez envoyer vos commentaires sur le balado d'aujourd'hui ou vos recommandations de sujets à communication@cos-sco.ca et nous essaierons de les intégrer dans les prochains épisodes.
Hi, I'm Anna Neufeld, and I listen to the EyeCan podcast.
I want to just take a second just to thank you again for sharing your story. I think so many of our members probably are suffering silently, just as you said, pushing on through the pain. And I think the more and more of us who come out and just speak about our experience helps give support to our community. I want to just touch back on the story that you gave us and just ask you about the sort of mindset you're in and your mental well-being through this whole process. Are you able to talk to us about that?
Yeah, it was a scary time for me. The first 2 or 3 weeks were very, very scary. I was in a lot of pain. I didn't know what was happening. I had a very difficult time navigating the system. And that sounds so strange, but it's true. I had all the benefits. I knew I had all the connections, but I went to the emergency room. I got a CT scan, which wasn't helpful or the right scan, and really had no follow-up after that. It was disjointed. So that was very, very difficult navigating the medical system. It was a hard time for me, no question. I think that after I figured out what surgery needed to be done and went forward with that, it was a little bit easier. But then the recovery was for me wasn't easy either. It was a very major surgery. There's a 2-inch scar on my neck. They push the esophagus to the side and move through to the spine to work there, right? So it was pretty major, the surgery. And I did feel that my mind was not as strong it took about 3, 4, 5 months to get back. I felt that I was just slow mentally, and majorly slow, in terms of my thought process, my ability to remember, think, etc. I started playing chess. I think that helped me. After about a month, I sort of felt like I needed something to get my brain back. And I think my brain's back to normal now. But I definitely took a hit, I think, through that surgical, spinal surgery or what have you. I was very lucky that I had an excellent surgeon and I've recovered very, very well.
I'm curious to know, as you look back at your journey and also, sharing with others how they can think about, the risks to all of our colleagues. Were there any warning signs, or do you feel like this you really had no warnings, and in some way that would be scarier if there are no warning signs? I'm wondering how we can help our colleagues realize that, this can happen at any stage to even healthier people who are active. What can you share with us in terms of warning signs or lack thereof, so that others can kind of think about how this might affect them?
I think the different stories are all important, right? For me, there was zero warning sign. So I was in good shape. I felt great. And then I didn't. And the MRI was obvious that there was, as I said, acute on chronic disease. So definitely scary. And again, it's the awareness, I think, for people to understand that is a possibility. And that did happen to me. There was zero warning sign. I'm sure that there's going to be there could be other podcasts with people who have had other back issues that have been much more chronic with, starting with pain, starting with, a process that progressed. And that would be important for people to know as well. But I think it's important that people know that this sort of thing can happen without warning, or of course it could happen with warning in another scenario. And I don't, neither of us three are physiotherapists or occupational therapists, but certainly back, neck pain and all that sort of common stuff, I'm sure is an issue.
Hussein, I'm wondering, sometimes in our conversations in the ergonomics world, we wonder how hospital systems could better support physicians, not just ophthalmologists, in preventing workplace-related MSK injuries. Do you have any thoughts on that?
Certainly the basics are important for all physicians, I'm sure. I had a occupational therapist come into my office about 10 years ago for a couple of hours in a consult because one of my staff was having some MSK issues. And she went through the basics. So desk height, where your keyboard is put, your chair, how that raises up and down. Then moving forward into dictation, saving a whole bunch of typing, possibly, artificial intelligence in, going forward and so forth. So I think there's that basic stuff. And then I think that there's ophthalmology specific stuff. And if you looked at, say Canada or an individual province or what have you, I think that there's probably enough that you could have an occupational therapist who just got some expertise in ophthalmology and could do some consulting sessions at various clinics. Certainly given, how busy all our clinics are, I don't think it would be unreasonable if you had a specialist, like an occupational therapist, for example, who came in and to a clinic every couple of years, and went through things. How do you set up the LIO? How do you set up your indirect? Do you have foot pedals for patient up and down? Do you have the right chairs? All that sort of stuff.
Yeah, I think that's a great comment, a really great suggestion, having somebody come in, look at your movements, our movements, and give suggestions on how to safely engage with these different tools that we use, as well as probably giving us, good exercises for that prehab, right? So that prehabilitation, getting ready for the next decade when we're going to injure more easily and heal more slowly, and we may not get 100% back. So great suggestions. Thanks very much.
Yeah, and just to follow up on that, I mean, you did mention the prehab and so forth, which, I think again, it's basic stuff, but the more that there's awareness of it, I do think that general health for ophthalmologists, as well as, of course, anybody and physicians, but, if you look at ophthalmology, having a little bit of strength exercise in your weekly routine, having maybe some yoga, having maybe making sure that you've got some core exercise in your weekly routine, all stuff that would be good for anybody, but certainly with our movements would be maybe a good idea. And again, around awareness.
I agree. And I think, Rishi's not wanting to toot his own horn in terms of his impact on this, but the COS Ergonomics Working Group is a great opportunity to highlight some of the work that they're doing. And so, for example, other things that we didn't get the chance to mention yet is residency education. I think residency programs are really a crux of ophthalmology in Canada. And so the more they're involved in this process, I think the better for everyone. I mean, one, they're the future, generation of ophthalmologists. Two, a lot of their faculty members are learning with them. A lot of their faculty members are up at the podium at our meetings and can help increase the awareness. I have colleagues who create these routines where they're doing exercises, whether it's strength training or mobility exercises between cases in the OR. They're doing it. They're encouraging the other people in the OR to do it. I think the more we talk about it, the more people are aware of it. I think the better for all of us. It just becomes part of the culture, so that this is not an awkward thing to do this stuff between cases or as a break in clinic, but really encouraged and celebrated. So I think we're moving in the right direction. There's a lot of room for improvement, and a podcast like this, your efforts to share your story, Hussein, and all the work that Rishi is doing with the COS Ergonomics Working Group. This is all going to help us move the dial, because it's just so important. As we prepare to wrap up this great chat, Hussein, Do you have any additional advice that you would give other physicians and ophthalmologists about prioritizing their own physical health and ergonomics? You know, it's not like you wanted to neglect your situation 10 years ago. I'm sure you cared about your health, but as you look back to where you were 10 years ago, not knowing how things would go, what advice would you give to yourself 10 years ago and to other colleagues that are maybe not thinking about this as much as they could or should?
Yeah, I agree with everything that you said there, absolutely. And I think that the priority of general health for physicians, for ophthalmologists, is really important, and taking care of yourself. Because if you're not taking care of yourself, then we can't help our patients. We can't take care of all the responsibilities that we have. So that goes with general fitness, general health, mobility, core strength, all those things that both of you guys have discussed. So certainly that's really, really important. In retrospect, absolutely, I wish that I had prioritized safe exam or ergonomics in my examinations. I think that would have made a big difference if I had done that for the past 20 years. So certainly taking the time and understanding that time is worth it, that you have to take care of yourself. You can't put yourself in a risky situation with, a patient in a wheelchair and tweaking your neck. Well, you just have to understand that's happening way more than just that once. It's happening over and over. It's repetitive, and you can't let that repetition happen. And again, of course, you need to take care of yourself, but you're taking care of yourself because you need to take care of your patients. You need to, there's a reason for it, right? And then the basic ergonomic things that we talked about as well. So the idea of taking care of yourself, taking care of your ergonomics, taking care of your general health, because if you don't, then it could be, an ergonomic issue. It could be a general health issue. And if you're not healthy as a physician or a ophthalmologist or what have you, then you can't continue to help other people, which is why we all got into this business.
A big challenge for me is, in a moment where, we have a patient in front of us who's in a difficult circumstance, whether it's wheelchair bound or kyphotic, or their body composition doesn't allow for us to do an ergonomic exam with them. I find it really hard to remind myself that, taking an extra few moments to set up the exam to be ergonomic for the ophthalmologist is beneficial for, the potential or the potential thousands of patients down the line that wouldn't be able to access care with me if I were to be injured. I find that dilemma, the patient in front of you who needs the eye exam right now versus, the thousands of patients years from now if you were to get injured. That's kind of a common scenario that I find hard to tackle. So I continue to work on that mindset to remind myself that, in those situations where you want to succumb to just doing the most convenient exam for that patient, that the right thing is to take an extra few moments to set up an ergonomic exam so you can kind of maintain your health long term. So I think that for me is a recurrent challenge. So as we wrap up, Hussein, we're going to throw you into a lightning round where we're going to throw questions at you to get to know you a little bit more. They're all meant to be light, so we're going to go ahead and get started. So are you more of a foam roller guy or a yoga stretch guy?
Yoga stretch guy.
Hussein, Hady had you pegged as a heavy metal guy for your playlist when you're going for a run, working out. Give us, what's on your playlist?
I can go a lot. Classic rock. I'll do a little bit of old school hip hop as well.
Give us your favorite song.
Oh gosh. The Red Hot Chili Peppers.
Are you a group workout guy or solo sessions?
I'm a probably solo sessions.
Would you pick a squash match or a mountain bike ride to de-stress?
Squash match.
Are you a Apple Watch type data collection person or you go by feel?
I was a data collection guy up until about 2 or 3 years ago, and now I'm all feel. Totally got rid of it.
I heard that Andrea Agassi never stretched. Are you a stretch before or stretch after, or are you an Agassi?
A bit in the middle, a little bit of stretch, a little bit before, a little bit after, probably should be more.
They say that you're not getting older, you just don't stretch enough.
Yeah, exactly.
Well, Hussein, that wraps up our chat. This has been so great. One, thanks for sharing your personal story for the benefit of Rishi and I and all our listeners. This has been really useful and touching to kind of go through your journey. We're glad you're better, and we're glad you're ready to share many of your learnings with us. So we wish you well, and thank you again.
Thank you very much. Yeah, thank you to both of you. I think you're both doing important work with the awareness and with all the work that you're doing here. Thank you.
Thanks very much, Hussein.
Thank you for joining us for this episode. We look forward to bringing you more engaging content over the coming months.
Merci de vous être joint à nous pour cet épisode. Nous avons hâte de vous proposer d'autres contenus captivants au cours des prochains mois.
EyeCan wants to know what you think. Please send your comments on today's episode or any suggestions you may have for topics or features to communications@cos-sco.ca, and we'll try to incorporate them into future episodes.
EyeCan veut savoir ce que vous en pensez. Veuillez envoyer vos commentaires sur le balado d'aujourd'hui ou vos recommandations de sujets à communication@cos-sco.ca et nous essaierons de les intégrer dans les prochains épisodes.
Thank you from the Canadian Ophthalmological Society.
Merci de la part de la Société canadienne d'ophthalmologie. Our sponsors for Season 6 of EyeCan are Stellus Pharma Canada and Johnson & Johnson Vision. We thank them for their support.
EyeCan is available wherever you listen to your podcasts, and of course, through the COS Practice Resource Center.
EyeCan est disponible partout où vous écoutez vos balados et bien sûr au Centre de ressources pour la pratique de la SCO.
Listening to EyeCan counts for unaccredited MOC credits. Listeners may claim 0.5 credits per hour under Section 2, which is individual learning as educational content review, and that can be done up to 30 credits per year.
EyeCan is written and directed by Kim Teitler and produced by John Allaire from Allaire Strategic Works.
EyeCan est écrit et réalisé par Kim Teitler et produit par John Allaire d'Allaire Strategic Works. Some episodes this season will include relevant links and show notes, so be sure to check episode descriptions to learn more. Certains épisodes de cette saison incluront des liens pertinents dans les notes d'émission, alors n'oubliez pas de consulter les descriptions des épisodes pour en savoir plus.
If any of our listeners have topic ideas to submit, please email them to communications@cos-sco.ca, and we will review for consideration.